Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at ETSU's Bill Gatton College of Pharmacy, and this episode is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. First, I want to give a shout out. Here I have some new listeners in Las Vegas. If you do hear this, make sure you tell Greg hi and thanks for the plug. Second piece of business. I got to circle back on something I kind of dismissed a few podcasts ago, and that was the approval of subcutaneous isatuximab. So isatuximab is the second CD38 targeting monoclonal antibody after daratumumab. So it's a bit late to the party and kind of a Me Too drug. And so when it was approved for the subQ administration, I honestly just skipped it. I just saw it. I didn't read anything else about it. And I assumed, and what happens when you assume? I assumed that this was a co-formulation with hyaluronidase or berhyaluronidase. That is not the case. It is giving like 10 mil of an antibody subcutaneously in one of two ways. One way is via a subcutaneous infusion, somewhat similar to what you do for atezolizumab given subQ. Or there is an on-body delivery device. Now this on-body delivery device looks more complicated than an Instapot. You've got to take the device and you've got to load the drug into the device. Then you've got to remove the sticky label, apply the device. Then there's like a safety tab that you have to pull, like a fire extinguisher. You got to pull that tab, and then you got to push a button, right? Now, every time there's a step, there's a chance for an error. So, this is the brand name of this is Sarclisa Xgena is the product for subQ administration. So I just want to clarify that because I kind of missed over that. So as you review that for addition to formulary and things like that, there is probably a large education component needed for the delivery, and there are two ways to deliver it subcutaneously, which is another potential source of confusion. Okay, I want to start with something that kind of caught my eye, and it turned out it was more exciting, the title and the abstract than what is actually there, but that's okay. So this was published in the Journal of Clinical Oncology last week, I think it was. This is a multi-center cohort study of original or substitute systemic therapy with or without brain radiotherapy for extensive stage small cell lung cancer patients with brain-only progression after first-line treatment. So you've got these patients, they're getting their platinum etoposide, they're getting their atezo, they're getting their durvalumab, right? So chemoimmunotherapy. They have progression, but the progression is only in their CNS. What do? Obviously, you would probably do some radiation, do some CNS-directed therapy, but then do you change your systemic therapy because it is providing good disease control below the neck? And this is not an uncommon question for other disease states as well. And this depends on are our drugs having activity in the CNS. And in small cell, platinum etoposide, they're not going to have a ton of activity. So this was a retrospective cohort study done in China. Now, so this is observational data, so it's not terribly strong, but it is a pretty large sample size. One of the flaws of this, I'm not sure what the standard practice is in China with regards to looking first for occult CNS metastasis. Here we do that for our small cell lung cancer patients. If they have good response, we do often give them radiation of the brain to prevent recurrence as well, especially for limited stage disease, although that's extrapolated to extensive stage disease in some centers. So this is extensive stage disease, and basically what they show is that there is, if you do brain-directed therapy with radiation, and then you continue the same systemic therapy that you were getting, especially if it was chemoimmunotherapy, kind of our current first-line standard, that was associated with better overall survival and better PFS2 versus switching to subsequent therapy. Okay, now the big caveat to this is most of these patients were enrolled in like 2022, 2023. The final patients here were enrolled in 2025. So this is really before we are incorporating tarlatamab as standard of care in the second-line setting, which does have CNS activity. So it's really hard to extrapolate from this, but it does give us some evidence, and I think intuitively makes sense that if your drug is controlling disease below the blood-brain barrier, it makes sense to continue that if you can get reasonable control in the blood-brain barrier, and you're able then to delay your second-line treatment even longer. Now, what was really caught my eye from this, and this could be some observation bias, you're only maybe studying people who are doing well, is that the median overall survival for the chemoimmunotherapy group, who then developed brain-only meds and got a brain radiation, was 38 months. That's really, really good for extensive stage small cell lung cancer, borderline unbelievable. So this was published in JCO. So a nice little publication to review if you're really into thoracic. I think maybe probably doesn't change any practice, but confirms what a lot of people would already do, which is helpful. A lot of you listen to the pod. You're new to oncology. You're just trying to learn, it's your first time in a role in oncology. You don't have training. You're just trying to get better understanding of a particular disease state. Well, to help, Kelly Karlstrom of the Kelly C PharmD and the ELO Collaborative created the Learning Oncology Companion. It's a free template that helps provide a framework that's structured for learning any cancer type, help you organize key concepts like risk factors, symptoms, biomarkers, and the predictive nature of those biomarkers, staging, treatment. Download this Learning Oncology Companion for free using the link in the show notes. Okay, the next item to talk about is an FDA approval for lutetium vipivotide tetraxetan. This is Pluvicto. Lutetium vipivotide tetraxetan. So this is a drug for prostate cancer. I'm going to use Pluvicto from now on. So this drug has 3 parts. It's been approved before in patients post-docetaxel. Then it's moved up to pre-docetaxel. And this is, kind of moving in the first-line setting. And this is the PSM addition, or PSMA addition study, depending on how you want to pronounce that. So real quickly, lutetium-177 is a beta emitter that is attached to a linker and chelator. That's the tetraxetan, and that provides a link between the radionucleotide and also chelates the radionucleotide to keep it in place. And that's then connected to vipivotide, which is the ligand that binds to the PMSA receptor that is primarily on these prostate cancer cells. So PMS addition is looking at standard ADT plus an androgen receptor pathway inhibitor like enzalutamide, darolutamide, apalutamide, or abiraterone, physician choice, plus or minus Pluvicto in the first-line setting. And we see this is FDA approved. We don't have the publication yet. This is this is a modest improvement in radiographic progression-free survival. So this is looking at imaging every so often to see, do we have new lesions. And, if you look at the Kaplan-Meier curve, you see the stair steps separate a little bit. And this small separation kind of matches what you see, which is a hazard ratio that's relatively a modest effect size of 0.72. That 95% confidence interval is 0.58 to 0.9. OS is immature. What I really want to see from the publication from this is that patients are randomized based on high volume or low volume disease based on the charted criteria. So those folks with high volume disease based on this charted study where they, in NEJM, probably now 10 years ago, where they gave docetaxel with ADT upfront to patients with newly diagnosed metastatic prostate cancer without an androgen receptor pathway inhibitor. This was before we were doing those early on. There was a huge improvement in overall survival, especially for those folks with high volume disease. Like the median OS was greater by 17 months in those who got docetaxel with high volume disease, which was, I think, more than 4 sites of disease, of metastatic disease, and they had to be outside, like just one. They couldn't all be bone mets, for example. So I do want to see how much of this benefit is in those folks with high volume disease on the study who are not getting docetaxel and are maybe being undertreated. That's what I would like to see from this study before kind of running with this. As Pluvicto moves up in treatment, another question I have is the availability and access to the drug. Anytime a drug company on their website has a find a treatment center on it, there's going to be an issue with access to this, because there are a lot of technical factors to safely administer this drug because it is a radiopharmaceutical. It's not easy to give, it's not easy to prepare, it's not easy to plan. And so as it moves further and further in treatment, that may make it harder for people to get access, where maybe it has the most benefit, which may or may not be in the first line setting, depending on what we see once this is published. But that data not yet out there, except for just kind of top line results in the label. So waiting for publication for that. And then the last tidbit I have is the Civic Pod study. So this is an investigator-initiated study, well-done investigators from India. And this is looking at pediatric patients. And it's testing kind of a concept that has been slowly building in supportive care and oncology, which is decreasing how much dexamethasone we use as an antiemetic. If we do a brief history of antiemetics in oncology, we didn't have anything great. In the 60s and 70s, we did high-dose metoclopramide because you would block dopamine and serotonin receptors at those very high doses. When you gave really high doses of metoclopramide, you'd get some extrapyramidal symptoms, so you'd give them some diphenhydramine or an anticholinergic to help balance that out. Didn't have a whole lot until on ondansetron. So now we're in the Zofran era, and things are much, much better. And we know that ondansetron plus dex is better than just ondansetron, and dex is readily available. It is the duct tape, the Swiss Army knife of oncology. And so you could kind of max your dexamethasone dose out at 20 milligrams. It's synergistic with 5-HT3 antagonists for acute nausea and vomiting, wonderfully effective at preventing delayed nausea and vomiting. It's cheap, readily available. Then we get the NK1 antagonist with aprepitant, and then IV fosaprepitant and relapitant, etc. And then we get the olanzapine data, where you're adding olanzapine in both the acute and the delayed period up to 4 days, improves both acute. It doesn't really help that much with acute, more so with preventing delayed nausea and vomiting. Most of this data is in the adult setting, and so for highly emetogenic patients, the guidelines would advocate for a 4-drug regimen, not always done in practice, with using extended duration of dex to 4 days if that highly emetogenic regimen is cisplatin. If it's a non-cisplatin but still considered highly emetogenic, just 1 day of dex. But not everyone's giving 4 drugs. So this is a study in children, in pediatrics, who are historically considered higher risk, that is a risk factor for CINV, chemotherapy-induced nausea and vomiting, younger age. So this is looking at, and they didn't do anything really fancy here, but they've done it, I think, pretty well. Arm 1 is the dex arm. So they're getting fosaprepitant, palonostrone, and dex. And then the olanzapine arm is fosaprepitant, palonostrone, and olanzapine. So, it's pretty much drug D versus drug O. Everything else is the same. I won't go through all of the methods necessarily here, but I will point out that they dose the corticosteroid appropriately with fosaprepitant, because you have to double your dose of dexamethasone or increase your dose after 48 hours of fosaprepitant, because the drug interaction with dexamethasone wears away. And so they've done that appropriately, better than even some studies that were published in the New England Journal of Medicine. And, it's a non-inferiority study, and that non-inferiority margin is minus 15%, which is a relatively large non-inferiority margin. But, I think it's pretty reasonable, and I think it's appropriate if you're going to have a small sample size. This sample size is 300. Again, I think that's reasonable for an investigator-initiated study that's not getting, funding from a drug company to do this. I will point out the median age here is 13. These kids had osteosarcoma and about 25%, Hodgkin's lymphoma about 20%, Ewing sarcoma and 20%, and the most common highly emetogenic regimens they're given are ABVD, ifos, doxorubicin, and cisplatin, and then vincristine, doxorubicin, cyclophosphamide, and then kind of other is the next most common. They are doing extended dex here, so they're doing dex, on the dex arm, they're getting dex on the days for acute nausea and vomiting, because it is helpful for preventing acute. And then that dex is extended for 3 days after the completion of chemo for delayed nausea and vomiting. Now, what we see overall here is the number of people who had no vomiting, and I'm rounding here, was 57% in the dex arm and 64% in the olanzapine arm. That's an improvement by about 6.6 percentage points favoring olanzapine. The lower bound of that 95% inferiority or 95% confidence interval is minus 0.45, not even close to minus 15. So certainly meets the criteria for non-inferiority, although with a small sample size. And the results for nausea are basically the same: 54 versus 54 having no nausea. So I think, we've seen this in some other studies in adults where we are limiting our dex just to day one and using olanzapine or using NK1 antagonists to try to, extended NK1 antagonists like Relaptant with a long half-life, Nitupatent with a long half-life to prevent delayed nausea, vomiting, allowing you to decrease your dex use. And I think that's reasonable if you really don't want to give dex, because you have really bad diabetes, it causes psychosis in patients or dysphoria. Certainly reasonable to limit dex in those folks maybe after you've given them that a trial. From a criticism standpoint, this means that about 40% of these kids are vomiting, which seems like we can do better than that by giving 4 drugs instead of 3 drugs. So that's sort of the now stated criticism of this trial. But I think it is fair. When I spent the last 2 years working a lot closer with multiple myeloma patients, and they really don't like taking the dex all the time in some cases. Although some patients, if they're taking weekly dex, they're like, that's my good day of the week because I'm not tired that day because I have energy from my dexamethasone. And I'm also reminded of an interview that Edie Falco gave for Fresh Air on NPR, 15 years ago, where she is talking, she's being interviewed about her experience acting. And she's a breast cancer survivor and took chemo for breast cancer, presumably AC followed by T. And she talks about in that interview the side effects and about feeling tired and things like that. And she talks about how the days after chemo were her best days because she's taking steroids afterwards. And she said those are the times I would plan to be out and about and do my things. And so there can be this quality of life benefit extending beyond nausea and vomiting control with dexamethasone. So, but I'm an old timer, getting to be an old timer. So I maybe am sticking to dexamethasone a little bit more, but still a very effective antiemetic. So that is what I have for you this week. Thank you so much for listening. You can follow me on X at PharmDeepNip and the podcast at OncoPharmPod at various social media platforms. And until I talk to you again, remember, doses matter.